Assalamualaikum and a very good day to the lecturer, Madam Rohana. Today I would like to present about healthcare management of COVID-19 around the world. First of all, this assessment will explore about healthcare management in the country by relating the topic of COVID-19 pandemic that have hit around the world. The selected country is the United States of America. The COVID-19 pandemic has damaged health system and economics around the world in 2020. But it was especially tragic in the United States, which had the highest number of recorded cases and deaths. The United States federal government's overall approach to the outbreak has been criticized, and state government have been chastised for implementing measures that were too relaxing prohibitions too soon. This pandemic has been resulted in more deaths in the United States as a result of this virus. It is more than simply cancer, dengue illness and vehicle accidents. Initially, many people underestimate the disease and did not take it seriously. This pandemic has caused lots of new immediate issue for healthcare delivery companies, such as insufficient capacity, supply shortage, and financial loss. However, healthcare organizations have taken the essential decision to release or cut personnel or cut shift many people to remote work, including physicians working with telehealth technologies in order to manage capacity and financial loss. It will be difficult for healthcare delivery organizations to modify capacity and reposition workers on short notice.
No one else does. Do I like that? It's easy to figure you out. If I can have you now, then easy.
The issues COVID-19 hospitalization are on the rise again across the USA. The first one, the United States is still weeks away from reaching a peak in the number of new COVID-19 cases, as the country continues to report skyrocketing rates of new infection as a result of the rapid spread of the highly infectious Omicron variant. And in the first 2 weeks of November, more than 1 million people in the United States were diagnosed with COVID-19. Day after day, the number of new cases increased in almost every state. The daily average for hospitalization stands at 100,000, up 80-90 from 2 weeks ago, and the daily average for COVID-19 variant. And the daily average for COVID-19 related death is 1,000, up 60% from 2 weeks ago. And new cases are rising across the USA, but are highest in northeastern states, including New York, New Jersey, and Rhode Island. The risk of infection remains high as daily new cases have hit record highs at the beginning of 2022. Underlying health conditions can worsen cases of coronavirus, and case fatality rates among confirmed COVID-19 patients increase with age. The highest number of deaths from COVID-19 have been among those aged 89 years and older, with this age group accounting for over 219,000 deaths. Coronavirus are a large group of viruses transmitted between animals and people that causes illnesses ranging from the common cold for several diseases. The novel coronavirus that is currently infecting humans was already circulating among certain animal species. The first human case of this new coronavirus strain was reported in China at the end of December 2019. The coronavirus was named Severe Acute Respiratory Syndrome Coronavirus 2 SARS-CoV-2 and its associated disease is known as COVID-19. COVID-19 expected to drive continued hospital usage throughout 2021. American hospitals face significant ongoing financial instability as the ravage of the COVID-19 pandemic continues to fester. In addition, hospitals are experiencing profound net income losses that likely will continue throughout the rest of 2021. Our latest analysis examines actual performance in the first and second quarters of this year and projection for the remainder of 2021. According to our estimate, more than a third of U.S. hospitals will maintain negative operating margin through year's end. However, the uncertain trajectory of the Delta and MU variants in the U.S. this fall could result in even greater losses due to many people will be affected with the virus and be hospitalized. As we can see, on statistics that have shown number of coronavirus COVID-19 cases, recoveries and deaths among the most impacted countries worldwide as of January 27, 2022, USA is the highest country compared to other countries with total infection is more than 70,000. And because of that, hospitalization in USA have been constantly rising for weeks, stating that the disease is spreading. Since the start of the pandemic, some elements have reduced the pressure on the healthcare system. In recent months, older population have made up a smaller proportion of new cases, lowering admission and mortality rates. Also, there are worries that the number of COVID-19 cases will keep hospitalization high, despite the fact that the Omicron variant, while more contagious, appears to cause less severe disease. Many of the locations with the highest relative pressure are in more rural areas of the country, where there may be few resources to support patients that in major metropolitan areas that experienced surge early in the pandemic. In the middle of this latest outbreak, hospital officials across the country are reporting staffing shortages as a result of the increased number of cases as well as the number of sick healthcare professionals. Dr. Jamila Taylor, Director of Healthcare Reform and a senior fellow at the Century Foundation, said that hospitalization are a more stringent measure, but with widespread testing, many patients who are admitted for other reasons can have a positive test, so that obscure COVID-19 specific admission. More than 4,000 hospitalized COVID patients give the state the highest rate of per capita COVID hospitalization in the country. And according to a CNBC analysis of HSS data, the volume of patient staffing challenges and duration of the pandemic have made this week more challenging than previous surges. However, this time hospitalization were more spread out in the age group, with those under 65 years making up roughly 60% of total hospitalizations compared to 50% back in January 2021. As of January 2021, around 22% of US adults think they would not get a vaccine that protects against the coronavirus if one becomes available. This static this week at the proportion of US adults who would get a coronavirus vaccine if it becomes available from January 2000 to January 2021. The Center for Disease Control and Prevention said on Wednesday about 251 million people have received at least one dose of a COVID-19 vaccine, including about 210 million people who have been fully vaccinated by Johnson & Johnson single-dose vaccine or the two-dose series made by Pfizer, BioNTech, and Moderna. Cases and deaths. Since the beginning of the pandemic, the United States that had reported 72 million COVID-19 cases, COVID-19 related deaths in the United States have now surpassed the actual cases. Dr. Lisa Marokaki, Senior Director of Infection Prevention for the Johns Hopkins Health System, also the vaccination number in the United States are not where they need to be, and she thinks despite their best effort, they are facing a future where it seems many people who are not vaccinated do not intend to get vaccinated. Also, according to CNCB, while the Global Scientific Committee investigates the strain's transmissibility and whether it can cause severe disease or evade some vaccine protection, nothing has changed in terms of what the United States needs to do to reduce COVID risk. Though infection with Omicron are thought to be milder, the surveillance in cases still means that hospitals are filling up. It takes about 2 weeks after cases first start to increase to see a rise in hospitalizations.
The U.S. has recorded more than 1 million new COVID-19 infections on Monday. That's a world record for confirmed daily cases, though it's partly because of a reporting backlog after the New Year's holiday.
No one else does. Do I like that? It's easy to figure you out if I can have you.
The United States healthcare and hospitality system is among the best and greatest in the world. According to a report, the United States healthcare system ranked 37 in the world, but the best are not exception from being affected by the COVID-19 pandemic. In August this year, the United States recorded the highest daily COVID-19 cases infection in 6 months. A public health official yesterday warned that the country had failed to curb the outbreak. The increase in highly contagious Delta variants worsened the situation, with the number of new cases per day rising to 180,000, the highest since last February. In addition, the new COVID-19 variant, Omicron, has now spread to 1/3 or in 16 states in the United States. The upsurge in COVID-19 cases has put a strong pressure on the national health system, which include facilities in hospital and also professional health staff as well as support staff. The pandemic has revealed the American healthcare system to be a non-system. Nowadays, COVID-19 is just one reason why so many hospitals are struggling. Hospitals are also feel the weight of high patient loads, while the number of nurses nationwide dwindles. Since April 2020, there has been at least 16 and 800,000 people hospitalized for COVID-19 in the United States over a 7-day period, and as many as 159,000, a new peak set last week. The country across the pandemic has averaged about 16,000 hospitalizations for COVID-19 a day. In January 2022, United States break COVID-19 hospitalization record at over 132,000 as Omicron surged. COVID-19 hospitalization in the United States reached a record high, according to the Reuters Teller, as a surge in infections caused by the highly contagious Omicron variant strains health system in several states. There are 132,646 people hospitalized with COVID-19, surpassing the record of 132,051 set in January last year. Hospitalization has increased steadily since late December, doubling in the last 3 weeks as Omicron quickly overtook Delta as the dominant version of the virus in the United States. In the United States between February 12 and March 16, 2020, the percentage of COVID-19 patients hospitalized with the disease increased with age. Findings estimate that up to 70% of adults aged 85 years and older were hospitalized. The same study also found that coronavirus patients aged 85 and older were at the highest risk of death. There are other risk factors besides age that can lead to serious illness. People with pre-existing medical conditions such as diabetes, heart disease, and lung disease can develop more severe symptoms. In the United States between January and May 2020, case fatality rates among confirmed COVID-19 patients were higher for those with underlying health conditions. The medical consequences of this latest surge could affect any American who needs medical care, whether for COVID-19 or another acute illness or injuries, because research showed that when hospital admissions reach crisis level, more patients die. Before Omicron hit, many United States hospitals were already faltering under heavy demand from patients infected with the Delta variants, as well as patients seeking care because of treatment that was put off early in the pandemic. In addition, the shortage of healthcare workers had reached crisis levels, and now huge number of doctors, nurses, and other healthcare workers are also testing positive and missing works, just as they are needed most. Following patterns seen in other countries, there are early signs in the United States that Omicron causes less severe disease than the Delta variants. Some hospitals are finding that fewer patients need ICU level care or mechanical ventilation. Dr. Sameh Kadri, an infectious disease and critical care physician at the National Institute of Health Clinical Center, said, "But the problem is Omicron is so transmissible, the sheer number of cases is going to be so high." Omicron's extreme infectiousness, when coupled with a depleted healthcare workforce, leave hospitals unable to provide the same standard of care for patients as they normally would. Kadri and his colleagues studied early surge and found that 1 in every 4 COVID-19 deaths was potentially caused by the strain of overcrowding. The most overwhelmed hospitals, where the demand for ventilators and other research instance care was greatest, the mortality rates for COVID-19 patients doubled. Dr. Kadri said, "What surprised me was the sheer magnitude of the impact. There are less eyes, less hands, and for these patients who require high precision care, that might mean the difference between life and death." Besides that, the United States hospitals were in financial shock and fee-for-service-based physical practice was devastated. For instance, health workers experienced severe level of fatigue during the 20 months of the COVID-19 pandemic. Because of that, thousands of healthcare workers of the Kaiser Permanente Institutes of Health Studies of the United States in Oregon and California were given the green light by unions to go on strike if talks on their contracts fail. The main thing demanded by them in the contract is regarding the grade of employment and salaries of nurses and other workers who have been frontline workers since the COVID-19 pandemic started. They urge Kaiser Permanente Management to offer fair contracts, thus tackling chronic labor shortage and security rather than forcing workers and putting them in danger simply to cut costs. United States need to move toward a genuine healthcare system that can withstand shock like the COVID-19 pandemic. There are already models out there to imitate. United States need to strengthen their worldwide pandemic and global health crisis alert systems. Despite concerns about China's early attempt to suppress the bad news about COVID-19, the world was lucky that Chinese investigators posted the full genome of SARS-CoV-2 in January 2020, the singular event that triggered the search for a vaccine. With the recurrent threat of yet another pandemic after H1N1, SARS, MERS, Ebola, and now SARS-CoV-2, along with the anticipated health consequences of global climate change, we cannot simply cross our fingers and hope to get lucky again.
No one else does. Do I like that? It's easy to figure you out. If I can have you now, then easy.
Okay, first is deep financial losses for providers. For the first time since the Great Depressions, crippling financial losses threaten the viability of substantial numbers of hospitals and office practices, especially those that were already financially vulnerable, including rural and safety net providers and primary care practices. The immediate cause of this unprecedented financial crisis is substantial, unexpected changes in demand for health services. On the one hand, a novel infectious illness has increased demand for specialized acute care that has overtaken some hospitals and imposed unexpected costs on many more. On the other hand, precipitous declines in demand for routine services have reduced providers' revenue. Office-based practices had a reduction of 60% in visit volume in the first month of the crisis, and by their own estimates, hospitals will lose an estimated 323.1 billion in 2020. Employment in the healthcare system is down by more than 1 million jobs. There are three contributing factors include: first, sicker patients. Hospitals are seeing more high acuity inpatient cases, including COVID-19 patients, requiring longer lengths of stay than prior to the pandemic in 2019. While such cases are contributing to revenue increases, any gains are offset by higher care costs of treating patients with more severe conditions. Second, higher expenses. Expenses are rising across the board as a hospital face increasing costs for labor, drug, purchase service, personal protective equipment which is PPE, and other medical and safety supplies needed to care for higher acuity patients. Third is fewer outpatient visits. Hospital outpatient visits, which tend to have lower expenses and higher margins, continue to grow but remain depressed compared to 2019 levels. They have yet to fully recover after plummeting with nationwide shutdowns and COVID-19 mitigation efforts in the early month of the pandemic in 2020. Providers' vulnerability to this demand fluctuation raises a fundamental question about the way they currently pay for healthcare in the United States. Providers operate as business that charge for service in a predominantly free-for-service marketplace. When the market for well-paid services collapse, so do healthcare providers. When the number of COVID-19 induced patients increases, this will have a significant stress and financial impact. Second is crisis in public health. The United States has 4% of the world population, but as of approximately 26% of its COVID-19 cases and 24% of its COVID-19 deaths. These startling figures reflect a deep crisis in United States public health system. Montana is now experiencing one of the biggest surges of the pandemic, with the highest rate of new cases and the second highest rate of the hospitalizations and death at this time. Put simply, the system failed to quickly identify and control the spread of the novel coronavirus. The United States did not make testing widely available early in the pandemic, was led to impose physical distancing guidelines, and has still not implemented either as widely as needed. At the same time, the shortage of workers in the public health sectors is the cause of hospitals getting full. Public health in the US was already poorly funded and understaffed before COVID hit. Many public health workers have faced long hours and short budgets while carrying out hysterically wide-scale campaigns around contact tracing, testing and vaccinating, all while seeing precipitous drops in public support and facing threats and harassment. More than 500 health officials have left the field through resignation, retirement, or termination since the beginning of the pandemic. More than 1 in 5 Americans have seen a local health official depart during the biggest health crisis in a century, taking with them decades in invaluable experience. In North Dakota, 3 consecutive state health officers resigned in 2020. National guidance on managing the pandemic has been inconsistent and delayed. Many states have now abandoned stringent physical distancing guidelines without careful attention to public health measures needed to prevent resurgence. Although inadequate leadership and excessive partisanship have played a role in these shortcomings, other factors are also in play. Public health in a quintessentially governmental functions, undertaking collectively for the public good at the national, state and local levels. In part because of many American distrust of government, public health functions have historically been under-resourced. The trained personnel who are needed for contact tracing, a traditional public health function long applied to such age-old afflictions as a tuberculosis and sexually transmitted disease are now scarce. Tellingly, there is no national public health information system, electronic or otherwise, that enables authorities to identify regional variations in the demand for and supply of resources critical to managing COVID-19. Without such informations, authorities have no way to direct vital resources from areas of surplus to areas of undersupply. It is no exaggeration to say that the United States currently lacks a functioning national system for responding to pandemics.
No one else does. Do I like that? It's easy to figure you out. If I can have you now, then easy.
United States of America healthcare management first solution is secure the finance of the healthcare system. Healthcare provider in the United States seem, if anything, overcompensated. Even now, many of the nation's wealthiest and prestigious healthcare institutions and practices can probably absorb and survive the immediate loss infected by COVID-19. However, the pandemic also shows that some hospital and health professionals are too vulnerable under current financial agreement, and the failure of this provider could leave major gaps in critical healthcare services. This raised obvious questions about whether the United States need a financing system that preserves essential health services in the face of market disruption. Part of solution might be to adopt payment models that sever the link between compensation and the volume of services provided. The most promising as a way to assure more secure funding for the healthcare industry is capitation, in which a provider organization receives prospective monthly payment for providing all necessary care to groups of patients. Medicare Advantage plans already operate under this system. Other than that, there are many variations on this theme, including capitation for selected services, or a combination of capitation with fee for service for certain types of care that might otherwise be undersupplied or are particularly valuable. For hospitals, a capitation equivalent might be a prospective annual budget for providing all necessary hospital services to patients in particular geographic areas. There is no perfect approach to compensating providers. One advantage of full of partial capitation and prospective budgeting is that they offer hospitals and health professionals a predictable stream of revenue that is unlinked from the volume of services provided. Capitation would have protected many providers against the short-term loss they are sustaining as a result of COVID-19. Reduce the need for immediate federal subsidies, now totaling hundreds of billions of dollars, and provided time to consider their amount and distribution with more care upfront. Global payments also offer providers the flexibility to innovate. For example, they could substitute virtual care for in-person care without worrying about telemedicine is compensated under fee-for-service rule. Payment models such as capitation would not completely stabilize the financing of vital healthcare services. If volume and associated costs to provider are consistently lower than expected, payers will insist on reduced capitation levels when existing agreements end. However, providers will have more time to plan for and adapt to such reductions than they have had in the early months of the pandemic. If reduced prepayment nevertheless threaten the availability of critical services, additional public policies may be necessary to subsidize providers who might jeopardize the health of communities. All capitated payment models should include measures of quality and efficiency to ensure that health professionals and institutions do not undersupply services, that compensation is proportional to the value provided. Another part of the financing puzzle is guaranteeing that essential services that were undersupported in fee for service markets before the pandemic are adequate in the future. This will mean public policy to shore up primary care services, behavioral health care, safety net providers, and rural health care services. The pandemic has shown the limitation of insufficient plan market in caring for Americans both in normal time and in emergency. Next solution is strengthen the capacity in public health. The new coronavirus is unlikely to be our final pandemic. To contain COVID-19 and prevent unnecessary suffering and economic loss from future pandemics, the US will need to strengthen its collective action capacity to defend the public's health. This starts with building the ability of state and local public health authorities to implement basic disease control measures such as testing, contact tracing, and isolation to affected persons, because states often lack the means to create these capabilities. Federal support and guidance would be required. And because microbes do not respect state boundaries, containing infection depends on cross-state coordination. Only the federal government can reliably lead such as interstate collaboration. The federal government currently lacks all the authorities need to play this role effectively. This leadership vacuum leaves the country unprepared to mount an effective and unified response to emerging infectious threats. Of all the problems highlighted by COVID-19, creating federal leadership capacity may be the most challenging. Some Americans simply have an aversion to centralized power of any kind, and an increase in the federal role would potentially shift the balance of power between Washington and state governments. Nevertheless, it is hard to imagine an effective approach to containing pandemic that doesn't involve national direction. As long as one state or region continues to harbor infection, the nation as a whole remains at risk. New federal legislation is necessary to clarify and bolster the ability of the federal government to intervene decisively and rapidly, and especially to require state and localities to implement critical health measures that are currently the responsibility of states, but are vital to health and welfare of persons in other states. This legislation would have several aims. First, it would enable the federal government to establish a national public health information system that provides real-time data on disease prevalence and incidence of illness, as well as on the availability of critical resources to treat affected patients. This system should connect state and local health departments with one another and with private healthcare providers, and require the participation of private healthcare facilities, laboratories, and manufacturers to give a complete picture of available resources. Second, it would allow the federal government to expand federal funds without prior congressional approval on emergency responses, including the development and distribution of new diagnostic tests, new therapeutic approaches, and new vaccines, and the hiring and training of personnel needed to track and contain epidemics at the local level. Third, it would let the federal government require states to adopt measures needed to contain the spread of infections. In particular, legislation could facilitate the use by the federal government of its constitutional powers to regulate interstate commerce by forcing states that did not comply with critical infection control measures to cease participation in interstate travel and commercial activities. Fourth, it would allow the federal government to regulate the distribution of new vaccines and antimicrobial agents. Fifth, it would grant the federal government emergency power to require state to allow licensed health professionals to participate in cross-state telehealth. The use of some of these authorities could be conditional on a presidential declaration of a public health emergency and could be time limited unless extended by Congress.
What else does? Do I like that? It's easy to figure you out. If I can have you now, then easy.
In conclusion, all countries, not only United States, will experience an increase in COVID-19 infection rates if not curbed successfully. COVID-19 will always mutate according to the situation, where there is a new variant such as Omicron that is stronger than the previous variant and poses a problem to healthcare system. This COVID-19 pandemic will continue to spread over the world in unpredictable human-caused conditions. As a result, the country's health, humanitarian, and socio-economic policies will advance and strengthen the country recovery from this epidemic. Healthcare professionals managing COVID-19 all over the world are in an unusual position. They were forced to make difficult decisions while working under extreme pressure. Of course, their various causes and natural have come together and interacted in the work attempt to recover from this disaster, and it is contributing to the complicated crisis. Therefore, healthcare companies that prioritize communication, connection, and innovation were able to effectively face the problem of adjusting capacity, redesigning service models, redeploying staff, and recovering the financial loss. Also, those in the recovery and rebuild stage, in particular, can use the COVID-19 epidemic as an opportunity to evolve into more agile and adaptable learning system. Overall, this pandemic has shown that basic treatment alone cannot manage the epidemic, with all hospitals being flexible and working with improved medical care to avoid the virus from spreading and reduce the number of patients infected. Indeed, in the case of a health crisis, all disaster management is dependent on the collaboration between the primary health administration as well as the other two healthcare specialists. The result after observing the healthcare management of COVID-19 in the United States, they vary greatly in terms of safety, effectiveness, and efficiency, as well as quality and cost, how the country managing the pandemic. So that's all from us. Thank you.
This is our world.